This webcast and any accompanying materials are copyrighted by the American Association for Respiratory Care. Any public display, sale, copy, or distribution of the video or materials may only be undertaken with the prior written consent of the AARC. Copyright 2021, all rights reserved. Good afternoon. My name is Ann Geiskemper. I am the Respiratory Care Clinical Manager for the Neonatal Pediatric Section at Rush University Medical Center in Chicago, Illinois. Welcome to today's program, Prevalence, Proportionality, and Cause of Ventilator Alarms in a Pediatric Intensive Care Setting. Program objectives. Upon completion of this AARC webcast, participants will be able to identify the research question of the study, identify the study design, discuss the main results of the study, and discuss the implication of the study on patient care. I am pleased to welcome Mr. John Emberger. Mr. Emberger is the Director of Respiratory Care at Christiana Care in Newark, Delaware. Neither Mr. Emberger nor I have any relationships to disclose. Brand names of products and/or medications may be mentioned only as examples of technology. Any use of brand names is not in any way meant to be an endorsement of a specific product, but to merely illustrate a point of emphasis and to provide information and education regarding the availability. John, welcome to the program.
Thank you. And I think we just saw the objectives, so we're going to move to the next slide. So we're discussing the paper that is the editor's choice for April in Respiratory Care Journal, as you heard it on the first slide. So we're going to start walking through this. We're going to walk through the background first of this paper, and one of the things that we're going to discuss first is what is the research question of this paper. The research question is to determine, pretty much as the title says, determine the frequency, prevalence rates, and the cause of both high and medium ventilator alarms in a pediatric critical care environment. Now they have, I have two sub-bullets there. I believe they also hope that this study will, as they've stated, hope that it'll generate new knowledge, that policymakers would develop or be able to develop alarm practice standards. As you'll hear throughout this talk, there's not a lot of research, and there's really no overreaching standards for this for alarms, which we see every day in the ICU. And I think they're also hoping that manufacturers can utilize this data as well as hopefully other studies to make their ventilators more effective at alarming for things that are safety issues and not having the burden of nuisance alarms. A little bit more on the background. Is this research question relevant? And I would say yes, it is definitely relevant from a paper standpoint. You're going to hear about safety throughout this talk. The alarms are pervasive. Ventilator alarms are pervasive. I don't have to tell you that if you're at bedside, and they cause alarm fatigue, which you'll hear about throughout this. The other thing is, reason that it's relevant is organizations such as Joint Commission, ECRI, and others have had concerns with alarms and have asked that alarms be set safely, but yet you'll hear, as the last bullet says, there's really no evidence for alarm management nor guidelines for alarms. So moving on to what is known about this subject. So a little bit more background before we jump into this particular paper. Alarms are supposed to help us identify things that are events that require caregivers. We know that there are issues associated with alarms, and they've been called into question. I have an upcoming slide, the next slide, in fact, that I get to, talking about how alarms have been called into question for harm or death. And then I have a couple other background slides, one speaking a little bit to alarm fatigue. We know alarm fatigue is real, and it's a burden on ICU staff, and ventilator alarms do contribute to that. And then another, I think, slide or two to just speak to the manufacturers, the ventilator manufacturers, and the pressure they have to be safe, and sometimes that pressure probably causes them to alarm up, to have more alarms, which can also cause greater fatigue, which actually can harm safety of patients as well. And again, I have a slide coming up about that. So the contributing factors, the fact that alarms have been called into question. As you see on this is a Joint Commission Sentinel event alert back in 2013. There were 98 related events. 80 of them were death-related. And if we look at the major contributing factors, I don't want to read through all this, but if you look at the first couple of bullet points there, inadequate alarm systems were identified, setting alarms improperly turning off alarms, which are really user or operator error, and then having audible alarms not really be able to be heard in all areas. And there were other factors that were identified. I would point out the alarm fatigue was the most common contributing factor on the top, as well as some issues around staff training and whether you have enough staff to respond or not. Getting in a little bit to the alarm fatigue, I will point to a Respiratory Care Journal article in 2019. Brady Scott was the first author of that, and this is I'm just going to you have a quote right out of this paper. To our knowledge, there are no accepted standards regarding mechanical ventilation alarm parameters, monitoring frequency, and or response to those or response expectations. So it's obvious the last line there that we should be adapting to the needs of the patient. But the point being, there really are no standards out there. They highlight in this paper on alarm fatigue things that could help ventilators be more effective, but not as detracting from an alarm fatigue standpoint. They gave 5 recommendations. These 5 recommendations, I'll just highlight a few points from there. Bullet point 1 is really to figure out how to notify clinicians immediately when we need to be notified. Point 2 is finding a balance between the safest level of monitoring but also reducing nuisance alarms. Bullet 3 really talks about alerting caregivers when not at the bedside and doing that effectively. And then they go into education, knowledge, and identifying how to set clinical alarms for unique situations. So they give recommendations on how to do alarms, but again, mention that there are no standards. I mentioned a couple slides ago that ventilator manufacturers are under pressure, and some of the pressures, just to point out some things, they're under pressure for litigation and for legal aspects. And I just thought it was interesting. These are all 4 of the main ventilators out there in the ICUs now, and warnings that they have in their manuals, which I think is interesting because when we think about alarms, the first one, if you look at the first line, it says this is not intended to be a comprehensive monitoring device. The darker gray one, it says, alarm limits may only be deactivated if it's safe for the patient to deactivate them. The one to the right that's grayish, never leave the patient unattended. Well, we always leave patients at times unattended, but they say never leave them unattended. And the one that's yellow, it says setting limits too high or too low defeats the purpose of the alarm system. Again, really very generic terms to just protect the company from litigation against problems like I have on this slide, next slide, which is, again, legal pressure on ventilator manufacturers to really alarm up. Each ventilator, the manual, if you look at them, I've pulled these manuals that I didn't have, the ventilators that we don't use, just to take a look in addition to the ones that we use. Every manual for ventilators has, that I've found, at least 40 to sometimes well over 100 different ventilator alarms that can go off on the patient. And as you can see, these images here are noted settlements of cases involving ventilator alarms. So there's there are legal pressures on ventilator companies as well as hospitals to set alarms properly and to make sure we don't miss anything. But if we set them too tight, as you'll see, we could probably create alarm fatigue. So back to some discussion around the background about this paper before we jump in. Are there any concerns about conflicts of interest? And the reality of this is that I don't see any external conflicts of interest noted from the authors. And whenever there are devices involved in research, you have to take that and really scrutinize and look at that. But I don't believe this paper has any conflicts of interest, even though there's specific devices noted. It doesn't appear certainly that anyone's benefiting from the devices that are mentioned in this paper. So I don't have any concerns about conflict of interest. So now we're going to jump into the methods section of this paper and walk through some information about the methods. So the first piece would be, what's the study design? And the study design, in this case, it's retrospective convenience sample or retrospective observational study. And I do want to remind everyone that retrospective observational studies are not strong levels of evidence. Above that would be things like randomized controlled trials, and then many of those types of randomized controlled trials contributing to systematic reviews and other types of evidence-based reviews. So the point being is, since Respiratory Care Journal is publishing a retrospective observational study on this topic, that's really a clue, because they're a very good journal, that there is not a lot of evidence out on this topic yet. So this is a retrospective convenience sample. As you see here, they gathered alarm data with a tool for 2 different ventilators in 2 different ICUs of the Children's Hospital of Los Angeles during that time that you see listed there. Their inclusion and exclusion criteria, was it appropriate? Well, it was a convenience sample, and it was basically all of the patients during that time period who were in the selected 2 ICUs on the selected 2 ventilators. So it's certainly a standard observational study. What is the control group? The control group, there is no control group. It's a retrospective observational study to assimilate some data on, but there is no group that they are being compared against. In the methods section, is the sample size appropriate, and was a power analysis performed? There was no power analysis formed. Power analysis would be performed to understand how many of a control versus a research group or a study group you would need to have significant results. So there's no comparison needed because there's no control group. And is the size appropriate? Well, my feeling is this 6-month sample that they did for all ventilator patients should be pretty adequate to understand the number, the types of alarms, and the around-the-clock situations you're going to run to with many different patients over 6 months in those units and on those ventilators. So I think it's a decent enough sample for the type of study that this is. And what are the threats to validity of this design? So what things can threaten that this was designed well or not well, or that type of thing? Well, the data gathered, it's a tool, it's a computerized tool that is going to collect the data. So there's really no threat to the data that you see here. The data is truly the data that was alarmed on the ventilators. So there's really not going to be a problem with that. The one threat to this, and you'll hear this at the end, is that the results are not generalizable. You will not necessarily find out any information in this paper that tells you about your patients on your ventilators. And we'll get to that in just a little bit, but it's not generalizable to other ventilators or other populations. Did they plan on statistical analysis, and was it appropriate for this study? So for this particular type of retrospective study, the analysis seems to be reasonably appropriate. Most of the data are simply counts, they're percentages, there's averaging involved. In fact, most of it was done in, they mentioned a lot of that being done in Microsoft Access. So it was not a super heavy statistical paper. They did use a two-sample z-test of proportions. And what this was used for is it was used to compare whether the populations in one unit versus another unit had a similar mix of ventilator alarms. So in other words, they compared, in this case, a PICU to a cardiothoracic ICU, and they wanted to look at, is there a statistically significant difference between the alarms they saw in those two units? And we'll get to that when we get to the results. Are there any ethical concerns? I did not see any concerns, ethical concerns, primarily because, number one, there were no clinical interventions. It's an observational study, and there's really no specific mention of patient characteristics or very specifics around patient and PHI and things like that. So there's really no ethical concerns that I can see in this paper. There are a few tables mentioned or shown in the methods section that I want to cover before we move on to the results of the study. And this first one here, this is the ventilator alarms description. It may be small depending on the screen that you're looking at, and I apologize for that. Most of the alarms on here are the normal alarms that everyone's probably used to, and they mean exactly what's stated. For example, an apnea alarm, a low peak pressure alarm, low tidal volume alarm, etc. The two that I really want to point out in case you don't have ventilators that have these alarms, there's one near the top that says circuit integrity. The circuit integrity is a proprietary alarm, and it basically is looking for an occlusion and also potentially to some extent a high pressure alarm. So that's the circuit integrity alarm. Proprietary on one of the ventilators, and then the bottom alarm is inspiratory flow over range. That one I want to call your attention to. That's another one that is a proprietary ventilator alarm by another one of the other company. And the gist of that is that it's the flow is outside, the inspiratory flow is outside a range based on the population setting that the ventilator is on. For example, neonatal versus adult have two different flow ranges. And this is basically saying the patient is getting on inspiration, is going higher than the flow range is supposed to be for that population. So both of those are proprietary alarms that I just wanted to point out before we move farther. The next table in the methods section is ventilator alarm parameter settings, and this is the standard clinical policy of the hospital. So if you look at these, they're probably nothing earth-shattering compared to what you do. They're probably pretty standard, and you can use clinical judgment to go outside of those ranges in the alarm parameter settings. But again, this is what is typically used at those institutions. Again, there are no standards universally for how to set alarms. And the last methods table I want to show is they've identified the two manufacturers of the ventilators and what the high priority versus medium priority alarms with the alarm descriptions. So really just to point out that there are a lot of different alarms that are high priority that were studied in this study. You can see several on the lower right-hand corner of this table for the medium priority alarms. Couple of those for one vent, couple of those for another vent. I think nothing earth-shattering here, just leveling the playing field to remind everybody of which alarms were high priority and medium priority for each of the ventilator types that they were looking at. So let's dive into the results of this study. So what they found in a sort of a high-level standpoint, there were 11 distinct alarms, and you'll see those in an upcoming slide. So 11 distinct alarms that they found during that 6 months. There were 47,000, a little over 47,000 unique alarms. for 2,091 days of mechanical ventilation that were looked at or analyzed. The data was pulled on. So about over 2,000 days of ventilators, actually nearly 50,000 alarm events found in that time. The overall prevalence rate, and what they mean by prevalence rate in here, and that's also going to be the same prevalence rate that you're going to hear in the discussion about a couple of other studies, is it's the number of alarms per patient day. So it's how many times each individual ventilator patient alarms that day. And the prevalence rate overall was 22.5. So believe it or not, some of you might be saying, wow, like that seems high, and some of you might be saying, why isn't it 100? 100 alarms per day. But anyway, their overall prevalence rate was 22.5 ventilator alarms per day per patient. And the interesting thing is if you take the three most common alarms, the three most common alarms are 69% of the alarms. And we'll get a peek at what those are in just a minute. And if you take two of the most common alarms, they were number one, medium priority alarms, and they were over half of the events, which is maybe kind of concerning because over half of the time it's only a medium priority alarm that's alarming. So if it's deemed a medium priority, maybe it's not a life-shattering event that we need to alarm fatigue everyone with. So anyway, those couple things are interesting. The number of common alarms, it's only a few alarms. In fact, we can see that on this next slide in the results. These are those 11 alarms that I mentioned, if you were to look along here. And this kind of reminds me of a Pareto chart in my performance improvement mind here, which is laid out from the least frequent to the most frequent. Pareto normally would be laid out the opposite way. But the interesting thing nonetheless is your eye moves to the right-hand side here, should anyway, to these alarms that are very common. In fact, if you look at the last four bars, by my calculation, the last four bars, the low PEEP, high airway pressure, high frequency, and the inspiratory flow over range, you've got 80% of your alarms represented by four unique alarms. And in fact, like we said, the three most common are actually 69% of the alarms. So several alarms very, very heavily contributing to the alarm burden. And the interesting thing, if you put your attention on the fact that, and this is just in my opinion, but I think of all these alarms, the most alarming to me would be apnea and probably low ventilation. I think those would probably be two of the most alarming ones to see. And maybe circuit integrity and low peak if it's for a disconnect. Well, all of those that probably are the worst case scenario situations, those are the vast minority of the alarms. So again, just looking at these, I think we've got an issue with alarms that may be alarm fatiguing us that are not necessarily the most dangerous looking alarms in the world. So if we look at some of the other results here, again, this may be small depending on the screen you're looking at it at, but this is the main results section that shows the prevalence values. So if you look at the bottom of the three columns, the last number in each column is the prevalence. So I mentioned the overall prevalence was 22.5. That was for the combined ICUs, both ICUs. If you look at the bottom of the first column, that's the PICU, the pediatric ICU, is 24.9. Bottom of the cardiothoracic ICU was 20.0. So what we actually have is we have the PICU being slightly higher than the average, and the cardiothoracic ICU is slightly lower, and both of those combined giving the average of 22.5. But we're in and around that low 20 to 25 range for this study for the prevalence. The other thing that you can note on this slide is that that in the pediatric ICU, there's a pretty even mix. In the cardiothoracic ICU, there's some that are not even really applicable. And at the very near the bottom of the column, the inspiratory flow over range is nearly half of the cardiothoracic ICU alarms, that inspiratory flow overrange. So that's a huge contributor in that one particular unit. Another way to cut up their data, instead of, which I should have mentioned, that last one was looking at it ICU to ICU, pediatric versus cardiothoracic. The other way to look at this is one ventilator versus another ventilator. So if we look at the AVIA is the left two columns and the servo I is the right, I guess 2 or 3 columns, 3 columns I guess it really is, of data here. I think the thing that sticks out to me the most is if you look at the bottom of each of the columns, the servo I has drastically more alarm events in this case, and what you'd see one step up from that is that inspiratory flow overrange is the largest, in fact, is over 40% of the alarms. So the servo I does have a lot more alarm events, and major contributing factor to those alarm events is the inspiratory flow overrange. And I made reference to the 2-proportion Z-test to statistically analyze if there was a difference between the alarms that you see in the pediatric ICU and in the other ICU, the cardiothoracic ICU. And in this case, if you look at the first column, you see these less than 0.001s. Well, first of all, I wanted to remind everybody, so whenever you statistically analyze with something like a Z-test, you have a null hypothesis. The null hypothesis would be that these units are similar or similar statistically. And you use a p-value of these to determine if it is statistically significant when you do the calculation. And the p-value, the stronger the p-value, is the stronger the evidence that against the null hypothesis, in this case against the fact that the ICU alarms are similar. And generally, a p-value of less than 0.05 is a statistically significant difference. So if you look down the 2 columns with the less thans in this case, they both really, on almost every parameter except one for the servo I only, they would be seen as statistically significantly different. So the pediatric ICUs appear to have a different character in what types of alarms go off in what percentages, according to this data here. And this final table that's in the results section, I'm lying to you, there's one more table after that. This table that I've come to now is a published range of, as you can see in the right-hand column, a proportion of clinical alarms that are caused by ventilators. So in other words, all of your alarms in the ICU, what percent of them are ventilator alarms? And this gives you a range of 16 to 45%. So somewhere probably in the range of 16 to 45% of the alarms, in this case from a published standpoint, they were caused by ventilator alarms, to just give you a feel for the significance of ventilator alarms contributing to the alarm burden in the ICUs. In fact, not everybody in the ICU is on ventilators, so ventilators are a strong force, even though not everyone's on one, to create alarms in the ICU environment. And now the last table that's listed in the results section, and this is some other published results, and I'll really just, if you recall, the prevalence in this study is in the 20, 22, and 24 range. That is this study. If you look at the top study here on the right-hand column, a previous pediatric ICU study showed 17.5 was the incidence rate of alarms per patient per day for ventilator patients. So this study is showing a little higher than previous pediatric ICU data. But I also want to draw your attention to the fact that if you look at some of these other values, there are values of as low as 1.3 alerts per ventilator per day, up to 168 or even 240 in the neonatal ICU. So there's a huge range of prevalence across, and this study confirms that it's maybe a little higher than back in the 90s for pediatric ICUs, and it's in the 20s per day or per patient per day for ventilators. So we're going to move on to the discussion section of this paper, and we're going to answer some more questions. How do these findings relate to previous findings from other studies? So, as I've already mentioned in the last couple of slides, this shows a higher prevalence than an earlier published pediatric ICU data, which they had 17.5, and this study shows the prevalence is in the 20s. It is lower than some of the newer adult data that shows upwards of, in some cases, 10 times this current study. That actually could be due to newer ventilators, could be due to the fact that they're using different settings or modes for the adult population. For example, in peds, they might be using pressure control a little more heavily, and in adults, they might be using volume control, and we know high pressure alarms can be a high contributor to alarms in adults if you've ever been in an adult ICU and listened to alarms there. So certainly this pediatric data is a little higher than previous published studies, but it appears that it's right in the range of previous data from other studies. So what do these findings mean? What do they tell us? I mean, in a nutshell, you've heard this. Ventilator alarms are common, and they probably contribute to alarm fatigue. Some of the frequent alarms are probably not indicating life-threatening situations, and they probably need to be looked at for refinement from manufacturers. And the other thing is, because of proprietary names, it's probably hard to generalize these. We cannot really compare types of ventilators, like types and frequencies of alarms between multiple different ventilators, just for the fact that they have different algorithms and different proprietary names for their alarms. How should these findings impact our practice? Well, every hospital, no doubt, because of Joint Commission and national patient safety goals, have to address alarms in plans and policies. And you should make sure that ventilators are included in your hospital's alarm management plans. Really due to, again, the specific types of ventilators in this specific PED population, you probably can't make many recommendations from this study for lots of hospitals across the country. But you probably should learn that hospitals should monitor their ventilator alarms for prevalence and for the types of alarms that are most frequent and those types of things. If you have the ability to monitor, you probably should. So what are the limitations to this study? The limitations are that it's a retrospective study. I already mentioned how that's not the strongest type of science. It's a single center. It was only 2 ventilators. It was a limited population. It was two different unique pediatric populations. And there's no standardization for methodology or terminology. We need extra information, and we need expanded data for ventilators. We need more patient populations to be able to start looking at and making recommendations for alarms. I want to make just a couple of quick comments about the editorial that was written on this paper. The editorial was The Conundrum of Mechanical Ventilation Alarms, and that was, again, also that was Brady Scott who wrote that this time in this April journal. And he speaks to the fact that the conundrum of ventilator alarms needs to be solved sooner. We need to be able to improve the outcomes, the safety of the patients, but also reduce the burden of alarms. He identifies in this paper alarm terminology, and alarms themselves are not universal. There's no standard for alarm settings and management, and research is very limited. And in the interest of time, he also mentions the 5 recommendations that were made in that Respiratory Care June 2019 article, which, again, I went through a little earlier, but they're good recommendations to read. They mentioned, he also brings into it smart alarms or artificial intelligence. So I want to mention this before we kind of conclude the paper, smart alarms, as you might hear of them, machine learning, artificial intelligence, these are the types of things that you might hear in the near future. There are already some of those types of things that have started, auto-increasing alarm volume. So if a nurse or a therapist is in a room, it starts out quiet, and that person can remedy the alarm, but then if there's no one there, then it finally does get louder. Therefore, it's not a nuisance alarm to the whole unit right from the get-go. You've probably seen high-pressure alarms being delayed by several different ventilators where you can turn that option on. Delayed in alarming or delay in sending the alarm to people is things that are up and coming. Another thing I should have put in the list here, but combining two or more alarms that might identify, in fact, this is a genuine safety event. Those are things that might come. And then middleware. Many of you might have gone to things where you have software that is actually sending the alarms out over pagers, phones, that types of things. That middleware can also be a method of reducing alarms to people where you only have certain alarms go out. I think I have two conclusion slides here. What are the author's conclusions? Well, number one, the lack of pediatric alarm data requires more research. And really, number two, hopefully getting more research will move us towards evidence-based alarm management. And hopefully we will be able to understand these characteristics that right now they vary greatly between ventilators. The alarms vary between ventilators. Also, the populations vary, and they cause different alarms. So we've got all these variables that we need more data on. We need more data on different ventilators, different populations, because there is a lack of data out there. And I believe the final slide is the conclusion here. How do you think this should change practice, and what's the take-home message? Well, how it should probably affect us is if we want to take alarms seriously, we should probably monitor our own alarms if we have the capability. And therefore, we could learn what is prevalent in our particular populations on our particular ventilators. Many new ventilators allow you to do this. You can some you need a computer program. You might need a thumb drive to download them on. You might be able to do it through your EMR or your documentation system. And then a really important thing that I remember always hearing people who taught me respiratory care is understand your device. So you have ventilators at your institutions. Understand your devices, the alarm settings, the algorithms that they use, so that you can consider exactly how your device works when you want to try to maximize the safety, but reduce all that extra noise. And now I guess I have time for questions.
Thank you so much, John. All right, the chat room is open there for a Q&A. I'm going to start us off with a question, John. So you mentioned the use of middleware, and I'm sure there are some institutions out there that do use middleware already. But since there's presumably already ventilator alarm fatigue, does implementing middleware contribute to that as well?
Well, so in addition to the local noise that you hear that's turned loud, yeah, I certainly think it could, because if you've now taken that local noise in the unit and you've put it to someone's belt clip or wherever they are getting those notifications, I think that certainly can. We've seen instances of that here where we bring more things online, and we have some middleware here that we use through a system that goes to our communications phones that we carry, and it can definitely. We had to tone back and change some of the parameters of what things go through and where they branch to, like who should it go to first before it goes to maybe everybody, that type of thing. So yeah, it could definitely contribute to alarm fatigue.
I completely agree with you. We also have a middleware system that pushes out to our devices, and I agree with you. I think it's about how you build that to try to reduce the alarm fatigue. It's kind of a catch-22, right? You want to be aware of the alarm so that you can kind of be proactive, but you're also then implementing more alarms to get to you. So great. Awesome. Thank you for answering that.
Sure.
Why aren't ventilator alarms perceived to be effective?
That's probably the 450 people on here could no. I think the perception is, it's so infrequent that you're called to a bedside, that with an alarm where something truly was needed to sort of save the patient, I think so many times, how often do you hear nurses, therapists out there, and you hear an alarm and they say, "Oh, don't worry about it. He's been doing that all day." I think they just need to get better. I think these and they've tried to do that with things like medium priority, thing we didn't mention here, but it's a standard from the FDA, right? Medium priority alarms have a sequence of 3 beeps, and high priority have a sequence of 5 beeps. And so they try to do that with these different beeps. They try to do it different ways, but the problem is that you have so many different patients. I think it's perceived as ineffective because of the fact that there's so many perceived false alarms compared to the number of true alarms that they feel like they respond to.
Great, thank you for that. Another question that came through, do you know, in terms of the limitations of this study, was there a consistent mode of ventilation used where these alarms were then seen in terms of the data collection to where that might have affected the results?
So I have this in front of me now. I've read this paper a few times, and I believe I did not see anything specific to settings or modes on these patients. I could be wrong. It did not jump out to me. I think I would have remembered that. So I don't believe we have that. We probably only have insight of that based on alarms. So there's certain alarms that are going to be more prevalent when there's pressure control versus a more volume-targeted or volume-controlled mode. But I don't believe we got any information specific to what these patients were on. We did get one thing that I didn't mention was we got a tendency in one unit they liked, I think it was in the PICU, they liked the Avia more, so it was more preferred and used probably more heavily. And in this cardiothoracic ICU, they liked, and the preference was the Servo I, so they used that more heavily in that unit. But they were used both in both units and that kind of thing. And I don't think we had anything about modes. Okay. Certainly didn't have any statistics. There were no statistics. I forget even if they mentioned any generalizations.
Okay. Great, something we can definitely look into. So with the high prevalence of alarm data, to your knowledge, has anyone looked at alarm prevalence including non-ventilator alarms? So, IV pumps or feeding pumps, things like that. And more specifically, what about the NICU setting where there is a large concern for growth and development of the premature infant?
I know data exists, as they even pointed out here, where people have looked at prevalence of alarms that were outside of ventilators because they showed what percent were ventilator alarms out of all of the alarms. So I know that exists. I'm just looking at that table now. I cannot recall a lot of NICU data. And the reason I say that, I didn't bring this up on here because it's not peer-reviewed, but we presented some NICU data for ventilator alarms, a similar type of thing, alarms that either got a person there by a button push and the prevalence of alarms as well as in adult ICUs. And I do recall there's that sensitivity for NICU. NICU, I can tell you, for what we do, because of the way the nurses are available and the therapist availability, we actually do the ramping alarm. We have the alarms low and then we let them ramp up in our NICU. That's our current practice, to try and keep it quiet for all the patients in general for alarms. But I'm not aware of, and in my looking, I have not seen a lot of people looking at lots of different types of alarms and or specifically in NICU.
Yeah, it sounds like there's an opportunity for a little bit more research in that area. I know that, the NICU is a very popular area for that heightened awareness in terms of the environment in which these premature infants grow. So I think if respiratory care has the opportunity to kind of give our contribution in that so that we are minimizing our alarms, I think that's a great plug for us. So anybody out there who's interested in research, there you go. Another question that came through. So what are the methods to monitor ventilator alarms in your own facility?
The methods to kind of collect this data, I guess, is what is being asked. Our ventilators, we can actually get a 1 week alarm. I think it's 1 week. Basically an alarm log with a thumb drive. So it's basically we have the ability to just pass through, put a thumb drive in and per ventilator and then pull out the data. And we've done that before to take a look at our alarms in-house here. And I believe that other ventilators, most of the newer ventilators have a method of that, whether it be docking some sort of a computer, using a thumb drive, or having some piece of software where they can pull it out. And in some cases, in this study, they had a proprietary tool with it looked like with their EMR system or their monitor system that was hooked up. And so it was a tool that was not part of the ventilator. It was that the ventilator was connected to it and basically dumping the data into it. So there's various methods, but it all really comes down to being able to probably plug in and interface to the ventilator so that you can either get some log of the alarms or you get them as they happen.
Understood. I know we talked a lot about in the one slide high priority alarms versus medium priority alarms. So a question about your thoughts on the medium priority alarms that the paper had noted.
Well, I think it's interesting that and I think it was certainly they weren't trying to hide it in the paper. Is the vast majority of the alarms or the largest contributor was that inspiratory flow over range on the one particular type of ventilator, and that alarm is an algorithm based, as I said when we were talking about the different types of alarms. That's an algorithm based alarm that you have no control over as a user. So the alarm goes off. And apparently, in some cases here, it goes off a lot. If the patient is, I believe if the patient is pulling more inspiratory flow than the ventilator thinks you should be able to pull, and it looks like there's not a whole lot of user control over that in some cases because they let this go on a lot. So that's one medium priority alarm that I personally would have some concern with. I think some of the other ones, it's again we don't have good, high high respiratory rate is one that's debatable. You can make the case for why it would be safe versus unsafe to allow the alarm to be maybe a little higher and not go off. So I think people are trying to do their best with clinical judgment. And some of these, the high pressure alarm and the high rate alarm, low PEEP alarm were common. And again, I think it's a clinical judgment thing that you just don't want it to cause allow harm to the patient where you don't catch it. But they're very commonly triggered medium priority alarms.
Thank you for that. Just a couple of comments that have come through in terms of perhaps an opportunity for some of our technology savvy people out there, that the ventilator alarms, some of them don't immediately silence, and they kind of have to go through their whole circuitry internally before they can be silent. What do you feel like would be an opportunity there for us to perhaps maybe influence some of these manufacturers about that?
Well, so I think I'm looking at the question there that you just mentioned. Just a few things come to mind. Some ventilators have tried to fix some of those frustrating things. For example, I see draining water from the tube or maybe even suctioning a patient. I know a lot of the ventilators now, for safety, whether this is good or bad, is that if you silence an alarm, if you hit alarm silence and then you disconnect the patient to do something, then every high priority alarm alarms once. I know that's the case with the ventilators that we have. So you get one of each of the high priority alarms that would go off for a disconnect if you're doing care with a patient and you know you're going to disconnect them for some reason, or you might accidentally disconnect them. What the manufacturers have done, I know what our manufacturer has done, is a button where you can say, I am planning on disconnecting this patient, and it gives you sort of a window of time where it will not alarm. Once it sees the patient reconnected, everything is back and engaged. So it took a user clicking that to get into that mode, so you don't get the alarms of the care maybe that you're doing in the room. But then once the patient is connected back, you get you have effective alarms again. So I know ventilators people have done that kind of stuff out there, so that you don't have that hassle of you press alarm silence, you create maybe a disconnect or something like that to, like I think the question says, draining the tubing. You won't get all the high priority alarms if you actually use that functionality.
I think that kind of segues into a question that I'm sure a lot of people are wondering. What kind of future studies do you think are needed to help us understand this topic better, but more importantly, to help improve patient safety?
It is sticky. I mean, I've thought about this a lot as I've read this paper, as we've done some analytics here in the hospital, as we've looked at the national patient safety goals and heard Joint Commission say that alarms need to be safer. And I think just like Brady's title is for the, it's definitely a conundrum, because you fall into the trap of to catch the important ones, you catch so many non-important ones. I do think that there's going to be something to do with, or I would hope that people would do something that's a little more smart, in that maybe they're able to suppress some of the alarms now that come through, and maybe couple some things together to, if you say this alarm and this alarm have gone off pretty much simultaneously, and they would know from learning and doing research on this stuff, that means this is going on with the patient, that we got to get a caregiver here immediately for them. So I think some smarter alarms will hopefully help with that. Although, again, the more I think about this, the more I think it's going to be really tough with the combination of litigation and hospitals wanting to be, safe, and ventilator companies want to compete with each other to say how they're being safe for patient care. That you've got all these things that are just ripe for lots of alarms to just make sure they catch the ones that are the most important ones. And I think it's going to be a very tough challenge to get the alarms that really, really matter. I mean, when you look at this, every generation, one of the papers I reviewed when I was getting ready for this, and I've seen this and knew this before, every generation of ventilators that have come out, I think were considered, depending on who you read, in this third or fourth generation of ventilators right now. The ventilators, every generation, have gotten more frequent and more complex, and more of these that are algorithms that we can't even change, we can't affect as caregivers.
And I think that kind of tails into, is there any way for us as clinicians to have some more structure with alarm management? And, is it something that you can put in within a policy or things like that? I don't know about your opinion, but for me, I feel like it's very much something that's kind of always evolving. So it's a hard thing to be able to implement within a policy, other than kind of stating the paragraph you kind of took from that paper about how it just needs to be kind of appropriate enough so that you're not, annoying, I guess, for lack of a better word,
Yes.
your staff and your patient, but also you can get a response as well.
Yes, yeah. It's tough. I mean, we have at our institution we have fairly similar, a couple other parameters mentioned, but fairly similar to the table that's in there of what their standard alarm settings were. And we also, as part of our policy, say, and then you can go outside of those based on clinical judgment. We ask people to comment, make a comment in the documentation for why they're outside of it. But people are constantly, I think our caregivers are constantly trying to tailor the alarms to what they see the patient doing, what they trust is not a big problem for the patient, to try and knock those alarms out, to just try and reduce that alarm fatigue. But it's very tough.
I agree with you completely. Well, John, thank you again for joining us today. Thanks also to everyone who attended today's webinar. Join us next on May 5th for a panel discussion on learning in a pandemic and the impact on clinical education and new hire orientation. You also can feel free to join us on May 21st to join us for the May JournalCast with Carl Hinkson. Thank you, everyone, and have a great day.
If you're a group participant, please have your group leader submit your information to the Group Attendance tab to be provided with follow-up instructions on how to submit for credit. If you have any questions, please email crce@aarc.org. This concludes today's presentation. To submit for credit, please click on the Credit Submission tab. Once finished, you may simply exit out of the browser window. We hope you have a great afternoon.